this is one study that looks at MACE, major adverse cardiovascular events. This was called the Postcard study, looking at plaque stratification using CTA and coronary artery disease. It was a retrospective pilot study for the Medical University of South Carolina for coronary CTA. They enrolled 640 patients, 3-year follow-up study, which is still ongoing. They looked at cap thickness. They looked at lipid-rich necrotic core volume, lesion length, and positive remodeling ratio, and looked for the association of these endpoints with major adverse cardiovascular events, or MACE. You can see in the slide, the green is how well stenosis performed to predict MACE events. The area under the curve was 0.7, certainly better than chance, but look at the improvement by adding more morphological measures. And now in yellow, we were able to identify with an AUC of 0.95, huge improvement in the area under the curve, a 30% improvement in the prediction of cardiovascular event risk by using plaque morphology measures on top of CT angio. And keep in mind, these images were already obtained. So this is just further analysis. There's no additional radiation or patient burden or scanning required to get these additional measures using Elucidvivo software. It also improved major adverse neurologic events, or MAIN prediction. This was a 200 patient retrospective study across a number of medical centers, including UMMC, the VA, Cleveland Clinic, and Cornell for carotid CTA, with up to a 6-year follow-up for MAIN. They now have a total of enrollment of 350 patients as we continue to look at this specific question. This is called the CRISP study, or the CRISP consortium. And you can see that the methodology include looking at matrix, occupancy of the matrix, lipid-rich necrotic core area, intraplaque hemorrhage, and calcification maximal area were all associated with intracarotid artery plaques ipsilateral to the stroke. You can see here, if we just use the NACIT analysis, the area under the curve was 0.55, not very good prediction. We had a 40% improvement in prediction of neurological event risk by plaque morphology. So as we think about adding these to MACE or MAIN, we could potentially reduce clinical trial size by up to 50% with prediction of those patients at baseline who are more likely to suffer an event, or more likely to benefit from therapies, and really dramatically reduce clinical trial size.